We move on to the next talk that's on multimodal imaging in central serous chorioretinopathy by Dr. Mahesh.
This one? Oh, that's it, sorry. Thank you. I will be speaking on the biomarkers, clinical and prognostic in multimodal imaging. So, clinical means it is not only imaging.
No,
Slide is not moving.
we can take 10 minutes
Yeah.
because we started
Okay.
late.
There are a lot of problems with CSCR. We don't know what is the ideal treatment. We don't know why it is severe in some people, and we don't know why it recurs in some. Still, we say it is self-limiting disease, and there is nothing to worry. So, we need predictors for diagnosis, treatment, and outcome. Outcome. So that is why there are new classifications by J. Chablani and et al., which mainly focuses on the biomarkers of central serous retinopathy. So these are important. Few clinical biomarkers, I will tell you. I can call it biomarker. It's a clinical finding, right? It's a clinical finding. Fibrin. Fibrin is one thing that we commonly see in many of the CSCR. It is vision will be very much affected, and the recovery time is very long. And it sometimes it can be even mistaken for choroiditis without. So the catch point is basically there is no vitreous cells, and you can see the angiogram with point leak. Now the other few biomarkers, sometimes we see some inferior little fluid, exudative detachment, where we see some subretinal fibrin. These are subretinal fibrosis. You can see that, and with some perivascular precipitates. These are some of the things that we should think about when diagnosing a central serous chorioretinopathy. So this in these cases, inferiorly fluid will be there. It should not be mistaken for rhabdomyovenous retinal detachment. Then there are angiographic markers. It is not markers. You can say ink blot and smokestack we see. Ink blot is commoner, and the smokestack leak usually have large serous macular detachment, while ink blot leakage can result in more metamorphopsia, less fluid. This is one thing that we usually see. Then there is chronic CSCR. Angiographically, there are a lot of findings. In fluorescent angiogram, we can see a lot of RP tract and staining of the RP. There are window defects corresponding to the loss of RP. And so these are all features of chronic CSCR. And these are, you can call it some biomarkers in angiogram. Now, fundus autofluorescence is one very useful investigation in CSCR. In fact, even in some cases where it is mistakenly said AMD or something, you can find out that this teardrop sign or peripapillary hyperautofluorescence patches, which tells you that this patient had a CSCR in the past. So this is there are two things. Fundus autofluorescence tells about the RP function. So when there is hypoautofluorescence, like the central area, RP is not at all functioning, and the thick RP is seen as hyperautofluorescence at the edge. So if it is totally dark, it is dead RP. The visual outcome may not be very good. So choroidal biomarkers are there. Already Dr. Lega has spoken about few things, choroidal thickness and everything. Choroidal thickness can be increased in CSCR. That is why it is coming under pachychoroid spectrum. We have seen patients when there is resolution of the fluid, choroidal thickness has reduced, like the top and below left side. Resolution of the fluid, choroidal thickness has reduced. And when there is a worsening of CSCR, choroidal thickness is increasing. So definitely there is a relation between choroidal thickness and CSCR. Then there is something called choroidal vascularity index, more of research things, but this also has implications in the pathogenesis of CSCR. Then there are some masquerades, or you can say like this is a case of diabetic retinopathy, and with a lot of microaneurysms in the fundus photo and angiogram, but you can see a small leak. So when you see such a large serous detachment, it is unlikely to be a diabetic retinopathy. Actually, it is little eccentric, not under the fovea. We see serous macular detachment, small serous detachment in diabetic maculopathy. Here it is little eccentric, and it's a large SMD. So large SMD, if you see, always think about central serous chorioretinopathy and not DME, or there is an underlying CSCR like picture in a DME. So then there are RP OCT biomarkers. regarding the RP integrity. You can see that RP is totally irregular with hyperreflective dots in that area, suggestive of even subretinal precipitates and all. So this RP integrity is one important thing that will tell you the prognosis of OCT, the treatment. And this is the top picture has RP atrophy. There is a total discontinuity, loss of RP in that area with ellipsoid loss. And there are cystoid degeneration. That is another biomarker that tells you that already it is a chronic one, and the outcome of your treatment, even if it becomes dry, it is not going to be good. We have few cases. I have this, the top ones are these are cases which I did PDT, that large serous detachment and even serous PED is there on the right side picture. And following that PDT, the resolution and even formation of ellipsoid line can be seen post treatment. Here the RP is totally not lost. So we can see these sort of conditions where there is a good prognosis. Here are a few bad cases. Initially, the top pictures, you can see that the RP is totally irregular, and there is loss of ellipsoid and RP in almost all the sections. In these cases, after PDT, even though there is an early resolution in the second line, it recurs after some time. And the right side lower picture is the bad outcome of a chronic CSCR, that is intraretinal schisis with gross thickening. They are not going to do well. So this is a case where we have done PDT, and post-treatment you can see that that even the ellipsoids on regenerates to some extent after some time. So these are better prognostic findings, and the other ones are bad prognostic findings. So this is another case, serous PED. Serous PED is seen in many cases of CSCR, and sometimes you can see that after treatment it collapses. Serous PED, we don't treat if there is only serous PED, but if you treat it, it may collapse after some time. And this is not a bad prognostic sign like a fibrovascular PED or notched PED or double layer sign, which is seen in some pachychoroid diseases. So this is the worst scenario, bad sick RP. We call it sick RP. Clinically also, lot of pigmentation, hard oxidate, staining, RP tract, peripapillary RP changes, and bad cases like the left eye, you can see that there is no RP at all. These all hypo autofluorescent. So these cases are not going to do well. So this is even after photodynamic therapy, nothing is happening, and these are very delayed cases which are not suitable for any treatment, which are still an enigma in our practice. Cystoid macular edema I have already told, and there is something called cystoid macular degeneration and posterior cystoid retinal degeneration, which are bad prognostic biomarkers in OCT. And these cases will not leak unlike a CSCR, the CME in other cases, there will not be any pooling of dye also. It will not leak also. Double layer sign is one thing that you have to see in many cases of CSCR, because it is going to be a precursor for the next step in pachychoroid, that is CSCR, then pachychoroid neovasculopathy and polyp. So this is a spectrum of disease. So if you see double layer sign and some notches, it is going to give problem in your future. Some cases may develop later. So this is, then I have one or two slides on octa biomarkers, and you can see that this is looking like a fibrin CSCR. There was a leak, and it was treated with micropulse laser, I think. And but later you can see the double layer sign, hyperreflective double layer sign, and then fibrovascular PD, not good sign. In fact, after treatment also there was no improvement after micropulse. Then octa showed neovascularization, that is a network there. So it is going into the next stage, PCN, pachychoroid neovasculopathy, and it was treated with anti-VEGF. Then it responded and became flat. But fibrin will take months to resolve, and some improvement has to come. It will take months. So these are some octa biomarkers you can see, and which will be useful. So this is the spectrum, and definitely you have to look at the other end also, because some of your cases will land up in the PCN and PCV later. So always think about these biomarkers when you treat CSCR. So that is it. And clinical and multimodal imaging biomarkers are very useful in the management of so-called simple central serous chorioretinopathy, which is the most elusive retinal disease. Thanking you. Thank you.